Good afternoon. Welcome to all of you. Welcome to our presenters for this session entitled From Research to Practice, Insights from Global Initiatives. Let me first give the floor to the first presenter, Diep Nguyen. That's correct? Yeah. Okay. It's called The Implementation of Methadone Maintenance Treatment in Vietnam, Scope and Review of Achievements and Challenges. Let me present briefly Dr. Diep Nguyen. She's a researcher and lecturer at Hanoi Medical University, holding both a medical degree and PhD in epidemiology. Specializing in addiction medicine, she actively engages in research, training, and clinical supervision in Vietnam. Dr. Diep serves as a national trainer and technical supervisor, having trained numerous practitioners in methadone maintenance treatment programs in Vietnam since 2014. Her extensive involvement includes participation in randomized clinical trials and evaluation studies aimed at assessing the effectiveness of diverse intervention approaches for individuals with substance use disorders. Dr. Diep's research interests center around pioneering and adaptive prevention and intervention models to provide effective support for individuals dealing with substance use disorders. Dr. Diep, the floor is yours. And of course, I remind you, you have 15 minutes.
Good afternoon, everyone. So I'm Diep Nguyen from Hanoi Medical University, Vietnam, and I also a member of Vietnam ITTC. So today I'm going to present with you our result of a scoping review of methadone maintenance treatment in Vietnam, achievement and challenges. Vietnam has a long history of opioid use, and up to now, methadone is the only maintenance treatment program in Vietnam that approved by the government. We started the pilot program in 2008 and scale up into. We start pilot the methadone program in 2008 and scale up nationwide in 2010. And in 2015, we decentralized methadone into primary care and pilot the take-home model in 2021. However, despite the effect, you can see that the number of people on methadone not increase over time, and we even observe a slightly decrease in the most recent year. It suggests that we have challenges with the program. We also observe a high rate of dropout of patients and the increasing trend of methamphetamine use. So with that, we conducted a scoping review of study on methadone maintenance treatment in Vietnam with two objectives. The first is to describe the outcomes and challenges of the methadone program in Vietnam. And the second is to determine direction of research that needs to be generated in order to improve the program. Articles that published in English on the methadone program in Vietnam we found from three resources, and from the 325 articles we after screening we include 83 in our review.
We review all.
Now come to the characteristic of our study. You can see that the number of articles varies over time, reflecting the implementation period of the methadone program. And we have a very much high number of articles in 2017 and 2018, after a very significant scale up in 2015. And although Vietnam have 63 provinces, most study was conducted in biggest city, Hanoi and Ho Chi Minh City, and some mountainous provinces in the north, where the epidemic is more serious than other regions. And more than half of study was cross-sectional study, or the qualitative method, and only few was the intervention study. We now come to the result, which fall into 4 domains. The first is the patient outcome with 42 articles. The second is program implementation, the social aspect and policies, and the cost effectiveness of the program. For the patient outcome, we see that half of the study report the patient outcome, and the outcome and the associated factors of these outcomes are consistent with other countries. We see the decreasing trend of the heroin use, improvement of quality of life, and also the decrease in HIV incident, ART uptake, and adherence. But also we found some challenges, especially the concurrent drug use, the lack of mental health support, and the stigma toward people on the treatment. And Vietnam has utilized different implementation models. The first one is the decentralized to primary care. It shows the improvement in access to and retain in care. However, the challenges is inadequate human resources and technical support. The integration model of MMT and ART treatment has shown to improve the quality of care and treatment outcomes. However, there is a lack of national mandate and guidance, and also a concern about the confidentiality of patients, especially the HIV status. The co-pay model have been proved that not impact the dropout rate, but we found that there would be financial barriers for patients with lower socio-economic status. And also the pilot take-home program has been piloted in 2021, 3 years ago. But unfortunately, we do not have a published article on the outcome of the program yet. And we also have some study that pilot the implementation of technology application. And most of the studies show that the good outcome by using the social media platform, web-based platform, SMS messaging to facilitate the communication between provider and patient, the referral system, and also to support the treatment adherence. And for now, we use the paper-based record and monitoring system, which are very prone to errors with limiting data analysis and program evaluation. And the published article also reflects that the landscape of policy in Vietnam has evolved over the past decade, that we see that more focus on the outcome of the research that inform the policy decision and make the treatment toward the more evidence-based and effectiveness, and also humanist approaches. But for the social aspect, study report that the improved social security, social support from families, and also peer support through CBO. However, there is persistence of stigma toward people who use drugs and also people on methadone treatment. The methadone program has been proved to be cost-effective through, although a small number of studies, but provides strong evidence to support the national scale-up of the program. When compared the methadone versus non-methadone of people who use drugs with HIV positive, it shows the decreased out-of-pocket health expenditure and cost-effectiveness. And it also more cost-effective when compared to the center-based compulsory treatment. And the integration model more cost-effective compared to the standalone model. So with all the results, in conclusion, the methadone program in Vietnam has achieved significant success in reducing illegal opioid use, stabilize the psychological well-being of patients, and facilitate community reintegration. And the diverse implementation models enhance the treatment outcomes and ensure the sustainability of the program. However, we still face several challenges, including the concurrent med use among methadone patients, and without any effective intervention available in the country for now. And the stigma toward people who use drugs and people on methadone remains significant, and which devastating the treatment outcomes. And also the limited scale of some implementation models and technology application, although they show promising results, but the scale is limited. And with that, we suggest the direction for future research. We would conduct more longitudinal study, as for now most of the study are cross-sectional. So to understand more the treatment outcome, and the intervention and implementation studies to address the concurrent and co-occurring issues that face the methadone on the methadone patient. And this slide, I provide with you a list of the published article in Vietnam. You can look for it if you need more information, more detailed information. And with that, I would like to end my presentation. Thank you.
Oh, thank you, Dr. Diep, and especially thank you for complying with the time frame. You're giving us extra, 5 minutes, so thank you so much, appreciate it. Okay, now we move on to presentation number 2. It's called Association Between Masculinity Norms and Alcohol Use Among Male Teachers in Muranga County, Kenya. And the presenter is Stephen Asatsa. Dr. Stephen Asatsa is a senior lecturer in the Department of Psychology at the Catholic University of Eastern Africa. He holds a PhD in counseling psychology from the Catholic University of Eastern Africa. His research interests include addiction, thanatology, and indigenous knowledge systems in psychology. He's also a licensed psychologist in Kenya in a private practice. So, Dr. Asatsa, the floor is yours.
Thank you for the introduction. Yeah, I come from Kenya, the Catholic University of Eastern Africa. And before I make my presentation, I always want to talk about Kenya briefly. We are known for long distance running. So whenever you are watching athletics marathon and you don't see a Kenyan there, that is not a marathon. It's only a marathon when there is a Kenyan. So I want to present on association between masculinity norms and alcohol use among male teachers. And this is an area of interest within a larger variable called the culture of honor, which has been studied in many countries, especially in the United States. There are many studies that have linked culture of honor and violence and other mental health dispositions. So masculinity is just one of the variables within the larger group of culture of honor. And when we talk about masculinity is how society views a man to be like, and of course there is also femininity. So in the Kenyan culture, it's highly patriarchal society. The man is still highly lifted in the society and very many responsibilities. So I just captured some of the expectations that most Kenyan cultures have on a man, and one of them is the man should provide for the wife and the family and protect them. The man should be strong and he should not show emotions publicly. That's why you'll find many men, when other people are crying, the men will not cry in public. Men should not show affection openly in the public. And naturally men are expected to be leaders and also in control. And then they are supposed to be self-reliant, and many times that affects a lot on seeking for help. Men will really go for seeking for help as a last option. They would really want fight and try to solve problems on their own before they actually go out and seek help from other people. And this is an area of concern because many mental health advocates in Kenya, they are always going out and telling men to go against this because they look at this as inhibitors of mental health. So men are being encouraged to cry, to share out when they have issues, and basically it is assumed men who have higher masculinity or men who conform to masculinity to a larger extent, they will exhibit negative mental health outcomes. And this is one of the reasons that made us to want to conduct this study and to see if there is any link between conforming to those masculinity norms and consumption of alcohol. And so our choice of the location of the study is one of the counties in Kenya, in the central region of Kenya, and that is one of the counties or the regions with the high prevalence of alcohol consumption. Many times in the media, the parents are complaining the young men cannot marry and have families. One time the media is reporting that schools, kindergarten schools are being closed because children are not being born. Men are heavily drinking to the point of not being able to function properly. So it has been an area of national concern, and there are many explanations. People have explained that phenomena in different ways, but we found maybe it's good to try to link, to try to do a study that links the aspect of masculinity. And the reason is because in this region, that's where, if we date back to colonial times, that's where the most colonialists settled, and so schools were built there. People are highly educated in that region, and the women empowerment programs seem to have worked. There is quite some balance between men and women in terms of power. So we wanted to look at if that could be a dynamic that could be affecting the direction in which men are consuming alcohol in that area. And just as it is nationally, the prevalence of consumption is very high among men. And so the hypothesis we developed is, or we hypothesized is that if conformity to masculinity norms would positively correlate with alcohol consumption. That's the assumption that we went to the field with. And we adopted mixed methods, embedded research design. So we wanted to look at, collect some data quantitatively and also conduct some focus group discussion so that we would be able to put meaning on some of the patterns that come from those numbers. And it's a small study, a sample of 422 male teachers, and this was selected from 6 sub-counties in that county, and this was representing 42, like we picked 42 participants with high alcohol use who were then later on interviewed. And we collected data using the masculine behavior scale and alcohol use disorders identification test, and the qualitative data was collected using the focus group discussion. This is just how our instruments bring out the data. Like this scale, the masculinity scale, is measuring masculinity in terms of success obsession, restrictive emotionality, inhibited affection, and exaggerated self-reliance. If we go back to how I presented the Kenyan man, what the Kenyan society expects a man to be, it really aligns with what this scale is trying to measure, because they are expected not to cry, not to show emotions. They are expected to be in charge. They are supposed to be in control. And this is what the scale is measuring, which I found it to be a scale that is really aligned to the culture. And we used the identification test here to look at the severity of alcohol use, and then the focus group discussion. So the results we have from the field, the study brings out a negative correlation between alcohol use and conformity to masculinity norms. And these are the results. Success obsession presenting a negative correlation, which is significant. Exaggerated self-reliance is presenting negative correlation. Restrictive emotionality, the same, and also inhibited affections. And that then leads us to reject the hypothesis. It has been assumed elsewhere that masculinity norms would correlate with high mental health problems, but as we can see, this is coming out in a different direction. And so we followed up with interviews. We asking the men who had high scores on the audit scale. We are following up to see, what could it be that is coming out in terms of their masculinity? Why masculinity and like masculinity seems to be a protective factor in that study, though it's not cause effect, but looking at it at face value, that's what seems to be coming out. And so we find the men have concerns. The men feel they have been overthrown. The men who had issues, they feel the empowerment programs that went on, they have overthrown the men. The women have taken over. They feel they are being sidelined. They have been neglected. And this is an issue that is also of concern, because in that area, the women empowerment programs began very many years ago. The woman is really empowered. She's actually in charge. And now we are starting to have a debate that we need to look at affirmative action with the boy child in mind, that you cannot empower one gender and leave the other, because if you leave the other one will become dangerous to the one that is empowered. So we need programs to try to bring a balance between the two genders. And the argument that has really gone on is like an empowered woman also needs an empowered man to match, because if you empower the woman and you leave the man not empowered, the man will become dangerous to the woman. And that's what we are trying to challenge on the ongoing program. So what is the implication? We are suggesting from this study that fight against drug abuse should be contextualized. As we have seen this study, it's actually not agreeing with studies that have been done elsewhere, which are linking conformity to masculinity and high culture of honor to mental health, negative mental health outcomes. This is a totally a study that is presenting dissenting results from the rest of the world. And so it's good to, when we are implementing treatment programs, we need to look at the cultural values of that particular area. And we also suggest the development of gender-focused interventions, so that not all interventions can just be presented equally. In such a society where there are distinct gender roles, there needs to be gender-focused interventions. And then from our study, we cannot conclude that masculinity causes low masculinity causes consumption of alcohol. We cannot conclude, because this was just a correlation study. And that's why we are suggesting it's an area that needs further investigation and possibly designing experiments in that line, so that we can be able to clearly test causality, and then we can make conclusive generalizations. And basically that's what our study brought out, and thank you so much for listening.
Thank you, Dr. Asatsa, for also sticking to the time. We'll stay in alcohol field, and we'll move on to third presentation. It's called Severe Alcohol Use Disorder and No Place to Live. Unmanaged alcohol programs to way forward, presented by Gabriela Novotna. Dr. Gabriela Novotna is an associate professor in the Faculty of Social Work at the University of Regina, Canada, and co-director of SFERU, Is that correct? Is that how you pronounce it?
Yes.
Okay. Her research focuses on informing clinical, organizational, and policy interventions for the issues related to substance use and misuse. Her research interests include studies on the uptake of research findings into health and social services, including policy and community university knowledge development and exchange. She has studied extensively the experiences of addiction professionals who are themselves in recovery and how their experiences relate to their clinical decision making. Dr. Gabriela Novotna, the floor is yours.
Thank you. Good afternoon, everybody. I'm going to try to navigate the presentation. So my goal today is to present my experience as an academic and researcher with a community-driven demand to provide an overview of research evidence on a quite novel harm reduction intervention for severe alcohol use disorders. And that harm reduction intervention is called managed alcohol programs. And managed alcohol programs are quite, I would say, a Canadian experience. The programs originated in Canada, and they were community-driven interventions for those who needed housing supports, but at the same time had severe alcohol use disorders. I will talk about benefits and challenges of these programs, and I also mention how these programs fared during the COVID-19 pandemic. And in conclusion, I want to share some of the observation based on the literature and also based on that community organization or experience. So we conducted a rapid review of literature that would consider managed alcohol programs for people with severe alcohol use disorder who also experienced homelessness and who have not benefited from traditional treatments, and by traditional treatments I mean abstinence-based treatments. These individuals who are part of managed alcohol programs usually have a long history of alcohol use disorder, and they are really the most vulnerable even among those who use alcohols. So we looked at peer-reviewed literature published since 2003 and focused on harm reduction interventions for alcohol use, and we also I added studies during COVID-19 after this small rapid review was completed. We searched the main databases such as Signal, Medline, Social Services, Abstracts, and Web of Science. We identified more than 40 relevant articles on the challenges and benefits of managed alcohol programs, and also managed alcohol programs during the COVID-19 public health measures. I want to emphasize that research on managed alcohol programs is still emerging, and the main credit for the research that was conducted in Canada should be given to the University of Victoria researchers in British Columbia who completed the evaluation of about 13 managed alcohol programs more than 10 years ago. So we, as a small research team, we really benefited from the researchers who paved the way to evaluate this emerging harm reduction intervention for severe alcohol use. And what we were asked to do by our community partner to collect the best research evidence and help them to advocate for a managed alcohol program in the community. After we collected research evidence, our community engagement included a panel discussion and engagement with the local media, and also advocacy for managed alcohol programs in the community. We also completed a final report, which was a summary of research evidence on managed alcohol programs. And last year, we managed to publish a manuscript based on this rapid literature review, which is an open access manuscript published in Substance Use Research and Treatment. So why to study or why to pay attention to severe alcohol use disorder among individuals who also experience homelessness? Well, they experience a much higher chronic disease, much higher experiences of trauma or other instability, housing instability, violence, and when they live on the streets, or even if they have some supported housing than the general population. In addition to that, because we deal with the population that is really vulnerable and experiences poverty, some of these individuals with chronic and severe alcohol use disorder would consume non-beverage alcohol. What do I mean by non-beverage alcohol? So these are the products that are not meant for the human consumptions. These would be hairsprays, these would be mouthwashes if they still have alcohol component, or this would be alcohol sanitizer. So really this is the population, a small subpopulation of people who have alcohol use disorders who are marginalized even within the community of those other alcohol users. And in addition to all the social and health complexities, some of these individuals have problems to sustain or maintain housing support. So our community partner really wanted to tailor some services to those most vulnerable and ask us to look at the research evidence and to look what those managed alcohol programs can do for some of their clients. I want to emphasize that managed alcohol programs in Canada, they are often connected to Housing First model. I'm not sure how many of you are familiar with Housing First model. So it came out of New York City, and researchers around Mr. Dr. Semberis were studying or emphasizing the need to provide housing, supportive housing to individuals who need it without asking them or insisting that if they use drugs or alcohol, that abstinence is what is needed for them to access housing. So Housing First, as you can hear from the name of the model, means the housing is first provided to all. And it's not contingent to abstinence, but rather clients are met where they are at. Housing First model uses two main kind of models. One is called the scattered housing sites, means that units or small apartments are scattered around the community. So these are individual kind of apartments. Or there is another model which is called single side housing, where we deal with one large building, and then in that single housing building we have multiple units, either apartments or individual rooms, where those who need supportive housing are housed. Managed alcohol programs are often an add-on to these housing supports. What are these managed alcohol programs? The aim is to reduce non-beverage alcohol use. right? The aim is to stabilize drinking patterns of those vulnerable individuals who otherwise would consume a very toxic non-beverage alcohol. Most managed alcohol programs in Canada would operate as a single-site permanent supporting housing sites, and in addition to managed alcohol programs, the supports as meals and medical care are offered. So MAPS, or managed alcohol programs, they have emerged as a response to several health and social crises and tragic by preventable deaths of individuals who use non-beverage alcohol or who couldn't manage their alcohol use in a way that would reduce the risks. So the logistics of managed alcohol programs are as follows. There are admissions criteria. These criteria mean that individuals are usually chronically homeless and they do need supportive housing. They have severe alcohol use disorder or engage in non-beverage alcohol use. They usually have had frequent police or emergency units contacts and unsuccessful treatments. So really we are talking about those most vulnerable. The support staff in managed alcohol programs would be healthcare providers, nurses, and social workers. And alcohol is administered, the regular alcohol, it's usually wine or beer, it's administered in controlled amounts throughout the day, and the servings are provided by the social workers or any other personnel. And the servings are adjusted to the intoxication levels. What these programs try to is to prevent clients to drink outside of the programs and really to, I would say, reduce and stabilize the overall functioning without asking them to quit alcohol altogether. So as I said, monitoring and reducing outside of the program consumptions, but there is also availability of detox or low alcohol drinks if somebody struggles to even function in managed alcohol programs. There are, as I said, challenges that some individuals need a lot of time, more time to adjust, and they still might drink outside of the program. There might be potential increase in alcohol consumptions if there is a daily drinking. And we also have to remember that clients who are in these programs, they already come as severely ill at the baseline. So the overall outcomes of these programs is often dignity and quality of life and support in the final stages of life of these individuals. There are certainly benefits. I want to end up with the benefits to the community and to those individuals. Policymakers like to hear that there are savings due to reducing drinking in the streets, reducing police contacts, stays in custodies, hospitals, and emergency rooms, and also there is better compliance with medications or daily regimes. Here is more information about one Ontario study who looked at the decrease in hospital admissions or police contacts. And also during the COVID-19 public health measures, managed alcohol programs kind of managed to see some favorable outcomes in preventing severe intoxication and minimizing the risk of spread of COVID-19. I want to conclude that this harm reduction strategy for severe alcohol use has been viewed as controversial. The social media, the general public react very passionately about it, and there is a lot of explaining needed. I want to say that single sites, housing first models usually work as the best manageable options, because these scattered sites required often support workers to come to those scattered sites multiple times a day. And this harm reduction intervention has been shown to work during the service disruptions, and also probably we could look at this harm reduction strategy as one of the health and social strategies and compassionate care for a few individuals. Thank you.
Perfect. Wow, we're right on time. Thank you so much, Dr. Novotna. Number 5 will be presented by Dr. Marina Piazza. It's called Appropriateness to International Quality Standards of Treatment for Use and Psychoactive Substances of Community Mental Health Centers in 2 regions of Peru. Dr. Marina Piazza is the International Technology Transfer Center Director of Peru and has significant research, consulting, and clinical experience in development and implementation of alcohol, drugs, and mental health prevention, intervention, and promotion programs at the local and national level. In the past 20 years, at the School of Public Health and Administration of the Universidad Peruana Cayetano Heredia, she has established leadership, creating and directing the alcohol, substance use, and mental health research unit. During the last years, she has participated in the World Mental Health Study, the Genesis Study, and the International Alcohol Research Study. She has led implementation research programs such as the WHO IPA Improvement Program implementation through embedded research initiatives, the scale-up of prevention and management of alcohol use disorders in Latin America, SCALA European Union's Horizon 2020 funding, among other studies. She will be joined also by Dr. Cecilia Chow. She is the co-director of the ITCC Peru. The floor is yours, both of you. Thank you. You have an hour and a half. Go ahead.
Which is ours?
Should we speak in English? Okay. It's going to be in English, right?
Yeah, it's
Okay, good.
Good afternoon. Hello. I'm so happy to be here, and I will present Appropriateness to International Quality Standards of Treatment Services for Use Psychoactive Substance of Community Mental Health Centers in 3 regions. Let me tell you that in our country, the Ministry of Health, right now the policy, we have these centers in our country. We have more than 200 of them. We belong to the ITTC, International Technology Transfer, and it's a program of the International Consortium of University and Drug Demand Reduction. The goal is to develop and strengthen the workforce organization and systems that provide substance use prevention, treatment, and recovery support services. Peru ITTC is hosted at Universidad Peruana Cayetano Heredia in collaboration with Pontificia Universidad Católica del Perú. ITTC is in both universities. The background international agree guidance. We review several of actual actual international standards of quality evaluation, and we review also the design to help countries help and deliver systems and services for the treatment of drug use disorder based on scientific evidence and human rights, recognized by the all UN member states. Also, we use the World Health Organization, these international standards for the treatment of drug use disorder, revised edition incorporating result of field testing. And also, we use the Handbook of Management Drug Use Disorder Treatment Services in line with international key quality standards, and the author is Dale Perea Annette. This quality standard, we will show some keys. I mean, it evaluates effectiveness of management of the service, and you can see some areas. For instance, it's one of them is the service adequately plans from delivery, treatment, and care for drug use. The service operates within established financial procedure, and so on. This is one area. The other area to evaluate is individualized patient-centered treatment and care. One aspect is patient assessment are comprehensive and participatory. The treatment and care are provided based on informed consent from patients. The third is timely access to evidence-based intervention, and one example is the service ensures timely access for its target groups. The service monitors and improves its outcomes and performance. And the fourth is promotion of patient health, safety, and human rights. Patients are treated with respect and are protected from abuse, malpractices, and discrimination. Patients are fully informed about service rules, policies, and procedures protecting confidentiality. These are the principal areas that we evaluate in these centers I mentioned. Priority of mental health policy in the creation, as I mentioned, of the community mental health centers network in the country, more than 280. Strengthen the incorporation of quality management in these centers, its regional territorial networks, and at the national level. Methodology, participation, and empowerment. The study aim is to evaluate to what extent management and care practices of treatment services for psychoactive substance users in community mental health centers of Peru are in line with key international quality standards that I presented. The following areas were evaluated: service management, provision of the individualized patient-centered treatment, timely access to evidence-based interventions, promotion of patient health, safety, and human rights. This is the timeline. First of all, we adapt this key quality assessment. We evaluate and report and improve. The methods. First of all, we pass the ethic committee, of course, to have the approval and to follow all the requirements. Then we adapted the instrument, specifically adequacy of criteria and wording, means of verification and scoring, with a team of experts. And then we evaluate. Our sample was 3 regions who were chosen, one in the coast, mountains, and jungle. Our country has 3 regions. All centers from each region were included, total 23. The pilot application of the instrument in center thus was not part of the sample, of course. And then presentation of the study online questionnaire to informants. We apply with the heads of the centers and the addiction services. Technical assistance and visit to the centers to solve doubts and verify sources of verification. Also, we have a team who travel to the regions to see what's going on, what they need, and etc. Analysis and presentation of results at national and regional level. Marina will present the report, areas of potential improvement. Thank you.
Great. So what we are listening today is a strategy based on the current situation of policy development of Peru, in which we are introducing the theme of quality improvement in a network of community mental health centers, where quality is not part of the activities. Community mental health centers have objectives in terms of clinically sessions or screening activities and that. So we are pushing forward policy, introducing that theme of quality to these professionals in a very simple way in order to promote sustainability and adoption. So we did this study, as Cecilia mentioned, with an instrument that was was included in a server, so had support of online, and that facilitated the completion of the questions. Each of the key quality criteria internationally had to be supported by documents that prove the level, high, medium, or low, of appropriateness that the chiefs of the services of psychoactive drug use or heads of the centers considered was the one that corresponded. So our respondents were professionals in community mental health centers that were either heads of the center or heads of the services. So what did we find? I'm going to present in general the results for the 3 regions, not specific by region, which we also have done the analysis. A weakness or an opportunity of improvement was user engagement. For example, users are not participating in general in the design or adjustment of these services. Also, users are not participating in the assurance of quality of the service. Also, the services are not using, as in other contexts, the experience of persons, for example, who had been recovered from substance use in the provision of services, which diminishes stigma for this type of users and for the service. And also, there was not user engagement in trying to promote access to specific groups, targeted groups that the services had decided were most important. The second area that in general was low, according to the international key quality standards that are all based in evidence, was quality management. These services did not have quality indicators about the provision of the service. And so they were not gathering information and including this information to improve their services. So quality was not part of their job, of the area of work. So there was also not regularly monitor and audit of the practice of the service, and also in reports in terms of cash expenses, and comply with national regulations, for example, according to fire regulations. And a third area that is an opportunity for improvement is availability of protocols. For example, protocols directed to addressing stigma and discrimination, to serving population with special needs, to management of major incidents, and also for control of infections. So, what do we do after these results? Now we will present what we did, what we are planning to do to improve. So what we did is we provided the results region by region, and the regional health director said, we want training. So we said, okay, we will provide training. But we've done a strategy that is training with technical assistance, in which we are providing training in some key concepts of quality management, but at the same time, we are promoting the development of plans for improvement of quality by regions, not by centers. At this point, by regions. So we created a team that is integrated by the national level of mental health coordination in the Ministry of Health. Why? Because we want them to be involved, to learn all the methodology, and to include, get involved in that. Also, we have regional health specific actors, like the quality director of the regional health office, the mental health coordinator of the regional health office, and also the heads of the centers and the services of drug use. So those are our teams. So what are we planning to launch, and we are adjusting the methodology with the Ministry of Health, is we are going to do a theoretical practical course with participatory methodology that seeks to strengthen the capacities in the management of quality principles and tools within health organizations. So some of the contents are principles of quality management, process analysis, quality improvement plans, quality improvement indicators. So this is a 12-week course with meetings every week, in which 45 minutes is of lecture, this is online, 25 minutes of work per regional team, and 20 minutes of plenary discussion, every week at the same time in 12 weeks. So at the end, the production of this course is regional quality improvement plans and quality monitoring systems that are created step by step during the class, the course. And in the last week of the course, they present their improvement plan to the regional health office. And in parallel way, we are going to launch a communication campaign to promote a culture of quality component that aims first to integrate the professionals in this concept of quality improvement as part of the responsibility. Also, the communication campaigns want to integrate users in treatment services, and this information, material and printed posters will be displayed in waiting rooms of the centers, and also will be disseminated by digital means. So, for example, this is a material that provides information about what are key quality standards, who are the main actors that should be involved, and then describes the areas that Cecilia introduced previously, the 4 areas of key quality care standards. And also we are still working on our poster, but the idea here, it says everything with you, nothing without you, in terms of incorporating the need to include and empower users. Thank you very much.
Thank you to both of you, Dr. Chow and Dr. Piazza. And we have plenty of time for your questions, so please go ahead. Please introduce yourself and then ask the question you want.
Hello, I'm a physician from Germany, and I work with the Methadone patients, Methadone program. And my question is for Dr. Novotna. This is the first time I hear that alcohol is being given to patients. So is it then a prescribed intervention? Who is covering the cost for the treatment, and who are the prescribers? Because I personally find in myself a confliction or a conflict because on the one side, as a doctor, I've done the Hippocratic Oath and promised not to harm my patients. So how do you go about prescribing and treating with alcohol? Thank you very much.
Thank you for the question and for your input. You are correct that this intervention is considered controversial by many professionals, but I can assure you that this is also considered a harm minimization measure in some clients of managed alcohol programs. So physicians are involved in assessing the clients of managed alcohol programs, and they very carefully do the assessment, and they looked at the evolution or anamnesis of the alcohol use disorder. Usually the individuals who become part of the managed alcohol programs have had multiple years of alcohol use disorder, and which has evolved. They have tried several times to abstain from alcohol, and they have other complex issues in addition to being homeless and using or consuming non-beverage alcohol. So for example, there is a physician who assesses the individual, how much they drink, what kind of non-beverage alcohol they consume, and then there are other team members as being part of the supportive housing, who consider all the complex issues that individual experiences, and then the physician has the say in terms of the dosage and the type of alcohol. Usually it is a beer or it is a wine, which is a lower percentage of alcohol, but the physician or a nurse, they are consulted in terms of avoiding the severe withdrawal symptoms for that particular client. When it comes to financing these programs, as I said, these programs are often a very last resort for those individuals. They are sometimes, I don't want to call it palliative care, but they might appear as such to some, because some of these individuals really have been through a lot over the course of their lives. In terms of financing, there are different models. Some programs would be financed by, if they are part of the research projects that were approved by the research ethics. Some programs would be type of co-ops where clients, they contribute with some money or fees from the social assistance. And during the public health, COVID-19 public health emergency, there were some health authorities that considered to contribute, but clients still covered certain fees. There are programs, some of the programs can be very small, like in a smaller city, it could be between 3 and 10 clients who are really in a state of not being able to manage the alcohol usage. And then there might be some larger programs that would have, for example, as small breweries that work as a co-ops. The alcohol is not being bought from the regular alcohol sales, but they would make it more cost effective that way. So.
Any other questions from the? Yes, please go ahead.
Hi. Hello. I'm Ann Chick from INL. I've seen you guys on screen, but never in person. So, Marina, this course that you have, the 12-week course for the training, that I gather is something you did with Colombo Plan. Is that something that can be shared under the program, or is that something that's very specific for you all that wouldn't be shareable?
It's absolutely shareable and improvable. Our contact information is in the last transparency. We can show. See, please. Yes, and we would appreciate very much your input. This is an effort of the International Technology Transfer Center of Peru, no? And it has been nurtured basically by the ICQ, the International Quality Control Network by Annette Dale Perea that trained us. And based on that training, we adapted the instrument, and designed the methodology. The key aspect for us is to do a simple assessment so that can be incorporated into the Ministry of Health, and to create change immediately after results that can be analyzed in a very simple way. So we have designed this in the context of a country with limited resources, to integrate the topic of quality, into the mental health arena.
Yeah, so it's the university that's doing the discussion, not the government, right?
It's an International Technology Transfer Center,
Right.
That is based in two universities, one in a School of Public Health and in the other university in a School of Psychology. Yes.
And does Rita plan to share the curriculum, or do we have to tell her to share the curriculum? Your course.
I always need to check with my bosses. Two of them present here, but all what we do, we used to hang in the ITTC network webpage. Yes.
Okay, thank you.
Anyone else? Another question? Presenters, you have the right to also ask questions to other presenters and to each other. If none, well, then we close the session. Thank you so much. Thank you, presenters, for the wonderful presentations. Thank you for attending. Thank you for the conference room staff, and thank you, interpreters, for being here. Thank you so much. Bye.